Michelle with StudentRegisteredNurseRN.com, and today my colleagues and I will be doing a presentation on premature labor in birth. So let's start out with what is it? So premature labor is defined as regular contractions and dilation of the cervix before 37 weeks gestation. If this cannot be stopped, it leads to preterm birth of an infant. Now this can be further divided into three categories. You have your late preterm, which is between 32 and 37 weeks gestation. You have your very preterm, which is between 28 and 32 weeks. And then you have your extremely preterm, which is less than 28 weeks. Now, some risk factors that can lead you to having a preterm infant is maternal hypertension, smoking, cigarette smoking, which Sonia will cover later on in the presentation, maternal age extremes, and that would be less than 16 or greater than 40, bacterial vaginosis, which actually increases your risk by 50%, and then you have a prior history of preterm delivery of an infant. So we're going to look out for all of these risk factors, and if the mother does present with any of these, then we're going to be on high alert that she may have a preterm infant.
Yep.
Hey y'all, it's Mary from StudentRegisteredNurseRN.com at Pierce College. I am going to be going over complications with preterm delivery in infants. One of the main complications with preterm infants is thermoregulation, right over there. With thermoregulation, as you know, preterm infants lack body fat, ergo, they're going to be cold. Another complication with preterm delivery in infants is hyperbilirubinemia that usually peaks between 5 to 7 days post-delivery, so keep an eye out on that. One more big stressor is respiratory distress. As you may know, preterm deliveries before 36 weeks gestation, fetal lungs are not developed. You are going to see some tachypnea, some accessory muscle usage, and lots of nasal flaring. So when you are taking care of these infants, make sure you are assessing their breathing. All right, y'all, another big complication with preterm delivery is neurodevelopment. As you know, the last 6 weeks of pregnancy is where the fetal brain starts to develop. That is when your gray matter, your white matter, and your cerebellum tends to develop. Preterm delivery before 34 weeks, you have a lower weight in brain size, which can cause long-term morbidities. Another complication is feeding problems. Your infants tend to have issues with sucking and rooting, and Juan will actually go into that further. One of the biggest complications with preterm delivery is infections. As with any delivery, as with any procedures, as with anything hospital related, you can get an infection. Our infections are broken down into 3 different categories. Congenital, which is what your mom had prior to delivery, whether it is HSV, HIV, gonorrhea, chlamydia. Those can all affect the fetal status. Early onset infections are generally the ones that you get during delivery, and then later onsets are complications that occur while the infant is growing, and that concludes complications with preterm delivery.
This is Juan with RegisteredStudentNurse.com, and I'm going to be going over feeding of a preterm infant. So first thing we want to consider when feeding a preterm is to make sure you try to use mom's breast milk first. Try breastfeeding the baby, but if the baby is unable to breastfeed due to lack of sucking motions or less than 34 weeks, then I would try to get an order for IV or NG tube feeding instead. Also, you want to fortify the breast milk because the vitamin D, amino acids, calcium, other nutrients aren't enough in the baby's own supply, so you want to actually supplement. Make sure you do it according to the NICU guidelines. Also, if mom's supply is low, you can either use formula or you can get some human donor milk in this place. So the only thing you want to watch for when using formula is a condition called necrotizing enterocolitis, which can happen when formula enters the baby's system, stays undigested, perforates the bowel, creates inflammation, and bacteria gathers. So then you end up having a death of the bowel. So to prevent that, you want to dilute the feedings, and you also want to spread out the feedings more frequently in smaller amounts, and also sit the baby up after the feeding is over to help with any aspiration or anything coming up afterwards.
Hey y'all, it's Sonia with StudentRegisteredNurseRN.com. Now that you've learned about risk factors, complications, and some treatment options for preterm birth, it's time to talk about preventing recurrent preterm birth. According to Rebecca Seifer at the Madigan Army Medical Center OBGYN department, the first step is to recognize women with prior preterm births. This is important to do at the initial prenatal visit. The patient's history should include presentation of preterm birth, inpatient management, and delivery outcomes. Once women who have had prior preterm births have been recognized, steps can be taken to predict and prevent recurrent preterm birth. Prediction strategies include transvaginal ultrasonography of the cervix and fetal fibronectin testing. Transvaginal ultrasonography is used to identify cervical effacement that is less than 33 millimeters at 16 to 20 weeks gestation and less than 25 millimeters at 20 to 24 weeks gestation. These measurements can sufficiently indicate possible spontaneous preterm birth before 35 weeks gestation. If the woman presents with these measurements, the transvaginal ultrasonography should be repeated every 2 weeks until 24 weeks gestation, and then weekly once the cervix reaches 25 to 29 millimeters. Fetal fibronectin is a glycoprotein that acts as a binding agent between the uterus and the pregnancy. In a typical pregnancy, the fetal fibronectin is secreted between 20 and 22 weeks gestation and after 37 weeks gestation. A positive fetal fibronectin test at any point besides the previously stated points is predictive of spontaneous preterm birth. Spontaneous preterm birth prediction may be enhanced when fetal fibronectin testing and transvaginal ultrasonography are used in combination. Preventative strategies for recurrent preterm birth include smoking cessation, treatment of asymptomatic bacteria, cerclage, and progesterone administration. Tobacco use is associated with 5 to 8% of preterm births and is associated with many adverse pregnancy consequences. Regardless of this, 30 to 40% of women continue to smoke when they are pregnant. As Rebecca Seifer stated, smoking cessation is the single most successful and patient-controlled intervention for preventing preterm birth. It all starts with effective screening and education of tobacco at the initial prenatal visit. As a tool us nurses can implement to help our patients is the 5 A's: ask, advise, assess, assist, and arrange. Pharmaceutical aids are not recommended during pregnancy. However, if the woman is unable to stop smoking without them, they can be used because, as we all know, long-term smoking is worse for the woman and the fetus than the short-term pharmaceutical aid. Treatment of asymptomatic bacteria is essential because the bladder infection may result in pyelonephritis, which is linked to 5% of preterm birth cases. Containing the infection equal to or less than 100,000 bacteria per milliliter decreases the occurrence of preterm birth by up to 40%. Pregnant women should be screened at the first prenatal visit, if positive, treated with antibiotics. Cerclage is defined by Rebecca Seifer as a surgical placement of a suture at the bottom of the cervix that is used to mechanically reinforce the strength of the cervix. It can be elective, urgent, or emergent. This procedure can have multiple complications and is typically reserved for women who have cervical effacement early in pregnancy. The final way of preventing preterm birth is progesterone administration. Progesterone administration can come in 2 forms: 17P, which is an IM injection, or vaginal progesterone suppositories. Naturally, progesterone acts as a uterine relaxant. Therefore, administration of progesterone allows the uterus to relax and decreases contractions and ideally prevents preterm labor. This medication administration can occur between 20 weeks and 36 weeks. And that concludes our presentation on preterm birth.
Making sure that if they have any of these, then we make sure that, hold on.
Complication with preterm delivery in infants is hyperbilirubinemia. Fully developed, you have comorbidities that
Ultrasonography of the cervix and fetal fibronectin testing. Transvaginal,
fetal fibronectin.
nectin, recognizing women with prior